Okay, so today we're going to talk about Denosumab. So Denosumab, the way it works, it's a fully human monoclonal antibody to the receptor activator of NF-kappa B ligand. So that's a bit of a mouthful, so we just call it RANKL. And basically RANKL is an osteoclast differentiating factor. And the way it works is it inhibits the osteoclast formation, which then decreases bone resorption, which will lead to an increased BMD, and then hopefully down the track a decreased fracture risk. So here's a more pretty picture, unfortunately in black and white, of what we've been talking about before. So here's the receptor activator of NF-kappa B, or RANKL. So that's these things here. And basically these are coming from osteoblasts. So osteoblasts and osteoclasts are in a constant yin and yang. So you've got RANKL, which is trying to turn on osteoblasts. You've got osteoprotegerin, which is basically trying to turn them off all the time, which is this thing here. So basically the balance between this will determine whether bone resorption is going on or whether bone resorption has been turned off. And so Denosumab is basically trying to tip that balance into the favour of osteoblasts being on and osteoclasts being turned off. And here's some Denosumab here binding to all of this RANKL to turn it off. So there's other agents that are used for osteoporosis, and here's the big trials for them. So alendronate was the FIT and the FIT2. There was residuronate, zoledronic acid in Horizon, and then raloxifene, estrogen replacement therapy, teriparatide, and then finally Denosumab. So I don't really have time to talk about all of them today, but as a medical student, you really need to know that the positives and negatives of each one is, and I'll include a table for that. So the first question with Denosumab is, does it work? Well, there's two big trials. They're called FREEDOM, which is pretty exciting. So there's a fracture reduction evaluation of Denosumab in osteoporosis every 6 months. And then there's FREEDOM Extension. So both of these were designed and funded by Amgen, which makes Denosumab. So you've always just got to be a little bit skeptical of these things. So the first trial was FREEDOM, almost 8,000 people between the ages 60 and 90, so a pretty good cohort. And you had to have osteoporosis, so a T-score of -2.5 to 4 at the lumbar spine or the total hip. And they basically then either had Denosumab, 60 milligrams subcut, or a placebo. And the original trial was 3 years, and it basically showed that the bone mineral density increased at the lumbar spine and the total hip compared with placebo, which is good. And then the biochemical markers of bone turnover were also significantly reduced. And then there was FREEDOM Extension, which basically put that trial out for another 2 years. And there was now only about 4,500 people. And then at this stage, 2,500 were active, 2,200 on placebo. And if you kept going, it basically showed increasing gains in bone mineral density as well. So to try and put that for the people that like pictures, is that the vertebral fractures are here and the non-vertebral fractures on the right-hand side. So we're just going to look at the FREEDOM 1, 2, and 3 initially. And so the cumulative incidence of a vertebral fracture at that time was 2.3 on Denosumab compared to 7.2% in placebo. So that's a pretty good relative risk reduction of 0.32. And I guess if you're looking at absolute risk reduction, that's looking at, almost 5%. The number needed to treat of around 20. For a non-vertebral fracture, not as dramatic. So the cumulative incidence was 6.5 in Denosumab versus 8.5 in the others. And then there was the FREEDOM Extension, which basically continued that out. And there's still some gain at that time. Looking at another graph here, we've got the time until first fracture. And so from a non-vertebral fracture, you can see that Denosumab has a lower incidence of first fracture. And then that also was shown in hip fractures as well. And that's over the first 36 months of the FREEDOM study. So that's great. We know that it's better than nothing, but now it's time to match it up against what our gold standard treatments are now. So there's been a couple of those. The only real head-to-head one is the Denosumab versus alendronate trial. So that was only done for a year, but basically it was quite clever. They used Denosumab every 6 months with a placebo alendronate, or they used alendronate with a placebo subcut injection. A bit over 1,000 people, had to have osteopenia really. And the outcome was really bone mineral density and biochemical markers. So there was a slight but significant greater effect on bone mineral density with Denosumab. So you can see that in the table on the right there, that Denosumab was ahead on all of those things. And there was significantly greater reductions in biochemical markers of bone turnover than alendronate as well. Unfortunately, it wasn't powered to examine fractures, which is a really big shortcoming given that's what you want to know from a patient point of view. The next question that came out is, can you use therapy sequentially? And it's a bit of a complicated question, but the short answer is yes. So there's one trial that used about 500 people, and this is from 2010, and they had people that had osteopenia to osteoporosis, and it was basically say, should they go on to denosumab or continue on alendronate, which was the treatment they were on beforehand. And after 12 months, there was more significant gains than if you continue with alendronate, so that's quite encouraging as well. Coming now to adverse effects from denosumab. So the common things are pain, hypercholesterolemia, and cystitis. And these come from basically the Amgen reported side effects. The uncommon things, but are more common, are eczema seemed to be worse with denosumab. Cellulitis was also worse with very low levels. And flatulence was a low level, but managed to make the list. So osteonecrosis of the jaw is an interesting area. So the Freedom Extension trial, fortunately weren't a lot of cases. So there were 4 cases in the long-term group who had 6 years of denosumab, and there was 2 in the crossover group, not group. So skin infection hypocalcemia rates were low, but there's also one atypical fracture in the crossover group. So the more information that's coming out of denosumab, we're seeing similar side effects that we see with bisphosphonates as well. So these may be actions that are a problem with anti-resorption in general rather than just one drug or another. So the main big problem that we're all worried about is hypocalcemia. So the important thing is that those 2 big trials of denosumab, people were on calcium and people were on vitamin D. And only a small amount had decreased calcium levels to less than 2.1 over the whole trial. So 1.7 versus 0.4%. So you think that level is pretty low. And in most of those people, it's transient asymptomatic. And the gist was that if someone had normal renal function, adequate calcium intake, and normal vitamin D, it just didn't happen. But that was not the whole story. So hypocalcemia can happen with some conditions that predispose you to it. So people with chronic kidney disease are at risk. People that aren't absorbing calcium, and people that have hypoparathyroidism also have problems. So if you tease out the chronic kidney disease associated with hypocalcemia, they were symptomatic and asymptomatic people. And for a creatinine clearance of 50 to 80, which is not that much decrease than normal, about 10% were getting hypocalcemia. And once that creatinine clearance got less than 30, up to 30% of people. And hemodialysis was there as well. So that's very common. And the nadir of this occurs at 10 days after administration. So the practical tip is that if someone has a borderline calcium, you should really correct that before you give them denosumab. And anyone that's got a predisposing condition should make you really worry about giving denosumab, or at least watching them more closely. So coming to the kidney disease and a little bit more info, if someone has a creatinine clearance less than 35, for denosumab license there's actually no restriction for it, but the actual trial excluded people that had hyperparathyroidism, which you can see will slice out a lot of renal patients. So the post-hoc analysis on Freedom actually stratified the study by the level of kidney function. And so if the GFR is greater than 30, they basically said you're probably not going to have any real problems. But there weren't enough people with low GFRs to really get a lot of information. So 73 out of the almost 8,000 people in the trial had a GFR of 15 to 30, stage 4. So there's not really enough events to draw any conclusions. And no one had a GFR of less than 15. So you're really going to uncharted territory with that. So there's really inadequate data with severe kidney disease and secondary hyperparathyroidism about what you're going to be doing with denosumab. And as with other trials in renal disease, you really need to make sure that osteoporosis is the correct diagnosis, because often hyperparathyroidism in renal bone disease has a stronger part to play. So another concern with denosumab is that if it's more potent than a bisphosphonate, could you get more problems as well? So there's really no good long-term data. So ONJ and atypical fractures have been reported. And there is some concern about whether you're going to stop fracture healing as well. So there was a pre-planned analysis of Freedom, which basically showed no difference in delayed healing even when given within 6 weeks of a fracture. And that was either before or after. So that's pretty good. So there were 2 in the denosumab and 5 on the placebo that had fractures. So fracture healing in mice basically shows it delays the removal of cartilage and remodeling of the callus, but improves the strength and stiffness of the healing fracture. So it had some positives, some negatives. The other concern is that rancor has some roles in the immune system, and the concerns that people have is that will it mess around with infection and neoplasm risk? So the early trial showed similar events compared with placebo and alendronate, so that's reassuring. But there have been some trials, like we showed before, that showed increased risk of infection requiring hospitalization. but the rates of cancer seem to be similar in the larger trials. So it's a sort of a watch this space at the moment. So I've probably scared you all off denosumab, but coming back to it now, when would you consider using it? So there's really no head-to-head trial comparing the anti-fracture efficacy with what we've got at the moment. And the vertebral fracture risk is similar to teriparatide and zoledronic acid, and it's greater than alendronate, so it's kind of on a level playing field. It's not recommended for osteoporosis prevention because we just don't have we don't really have any long-term safety data, and there's really no consensus yet on its optimal use. So there's some people that are very die-hard and think that it should not be an initial therapy because we know how to use bisphosphonates, we know what their side effects are and how to dose them. Having said that, there's some people that say it should be first line, so if the patient prefers it, dosing can be difficult. If it's zoledronic acid, you've got to bring to hospital once a year. The presumed roll down the track is that obviously if someone doesn't respond or is intolerant of other therapies, then denosumab has a good role here. And if someone with impaired renal function, but as we can see, if you pour through the trial data a bit more closely, there's probably not enough of an indication or safety data to really make a comment on that. And then for men, there's really few studies that looked at osteoporosis that aren't on androgen deprivation therapy, but you can get it on the PBS. And it really is not intended for use at this stage for premenopausal women or kids. So here's a little bit of a cut and paste that I've got from the PBS. So you need to think about how much the drug's going to cost. So this is from the start of March 2014, so things might change. So you've got alendronate, which is the cheapie at the top. So that's going to cost you $21 for roughly a month's supply. So if we times that as 4 by 13 to give it how much it's going to cost in a year, it's about $360. Zoledronic acid once a year is going to cost you just around $600 a pop. And denosumab's just slightly more expensive. So cost alone over zoledronic acid is probably much of muchness, isn't it? The next question after you've started using it is how long should it be used? And we really don't have any good data about the duration of therapy or what the next sequential therapy is. We know that if you stop denosumab, the effects are reversible with cessation. So we know that bone turnover markers start shooting up within 3 to 6 months. And if you stop denosumab completely, it takes about 2 years to be as if you never had any treatment as well. But then when you chuck them back on denosumab, you get a more rapid onset offset than bisphosphonates. We don't really have any data whether that more rapid onset offset has any correlation with fracture risk. So denosumab has some uses outside osteoporosis, which is starting to get a little bit off topic. But men on androgen deprivation therapy for basically prostate cancer, it's been shown to prevent osteoporosis and vertebral fractures. For women undergoing breast cancer treatment, they love it. So it increases bone mineral density in those receiving adjuvant aromatase inhibitor therapy. And the denosumab in this section is given, every month, which is pretty frequent. So they get more hypercalcemia, they get about the same level of ONJ, and the kidney function you don't need to worry about, which is good. In bone metastases, it's just as effective as zoledronic acid. And in multiple myeloma, it seems to be pretty good. And that's really about all we're going to go to for that today. So just a general approach for someone you're thinking of using denosumab in. The pre-treatment thing is basically the same as anyone with osteoporosis. Look for a secondary cause. Are they on steroids? Do they smoke? Is their thyroid okay? Is their parathyroid okay? The next point's the key one. Make sure that calcium and vitamin D is corrected. Consider the ONJ risk. So obviously if someone's got half their teeth falling out, you might want to fix them first. You then give them the injection at 60 milligrams every 6 months. And then for the people that are more at risk, you should check the calcium in about 10 days. So people with chronic kidney disease, people with malabsorption, people with hyperparathyroidism, or have had messing around with their thyroid in the past, you should probably do this. Patients are advised to monitor for a skin reaction like eczema or any signs of infection and to see doctors if that happens. And then bone mineral density, we're not really sure when you should do this, but the recommendation at this stage is probably no sooner than 2 years. And so that's really all I've got for